Multiple sclerosis. How can we stop disability progression? The story of restoring myelin. Hello, I'm Dr. Susan van Rensburg. I would like to share some insights that we have gained over the past years regarding multiple sclerosis. First, I would like to give a brief overview of the diagnosis of MS, which includes assessment of clinical symptoms as well as MRI. On MRI, we find white matter lesions, which indicate localized areas of damage due to inflammation. In addition, a neurological test is done to determine the amount of disability, using a test that was devised by Kurtzke in 1983. This important test is called the Expanded Disability Status Scale, or EDSS for short. It has become the gold standard because it can measure changes in disability over time. It is an objective test. Several doctors can do it and they will get the same result. So it is used in all clinical trials and for research. It is very useful because it provides a measure of disability on a scale of 0 to 10. The lower the EDSS value, the better. A normal neurological exam tests at 0. 4.5 indicates relatively severe disability, but the person is able to walk without aid for 300 meters. At 6, the person needs assistance with a cane, crutch or brace, and at 7.5 they are unable to take more than a few steps and are restricted to a wheelchair, and 10 indicates death due to MS. 0 to 3 is regarded as benign MS, where people go about their lives without serious disability. Most websites about MS proclaim the incorrect news that disability progression is inevitable. They paint a scenario in which you fall into this whole diagnosis. You are then treated with drugs that can extend the time until you actually walk with a stick or are in a wheelchair. But the point is that you stay in the disability hole. Once you've fallen in there, you don't get out. But is that really true? What is the evidence that disability can be reversed, or that MS can remain benign over a period of many years? Well, there was a recent study in Canada, published in the Multiple Sclerosis Journal of 2012, with the title, Natural Innate Improvements in Multiple Sclerosis Disability. The researchers wanted to find out whether people diagnosed with MS could improve spontaneously. That is, when they were not on MS medicines. So they evaluated 16,000 EDSS scores, and they found that up to 30% of people experienced improvements in the EDSS over 1 year and 2 years. There were even improvements in people with primary progressive MS. And then there were studies done in America, published in 2004 and 2008. These studies measured the EDSS scores over 10 years and 20 years. They found that if MS patients had EDSS scores of 2 or lower for a period of 5 to 10 years, they had a very small risk of developing disability over the next 10 to 20 years. What do we learn from these studies? We learn that some people show disability progression, but some don't. So what does that mean? That is the main aim of our research. We are investigating whether we can identify the risk factors that predispose to disability progression and whether it is possible to reverse the process if we alleviate the risk factors. And that's exactly what we've been finding. In 2006, we published the results of a study showing that people who stayed on our intervention program improved over 6 months, from a mean EDSS of 3.5 to 2.45. Remember, the lower the score, the better. When we followed them up after 7 years, they had improved even more, to a mean of 1.4, which is a very low EDSS. All of them had an EDSS of less than 2.5, which is benign MS. People who did not stay on our program actually had a worse outcome after 7 years of 8.4. These results were published as a Congress abstract in 2013. Now you can see that the people following our program went on with their lives. They were employed or they were active, and the people who did not follow our program are in wheelchairs, and some of them have even died. Now, why is that so? Well, we will have to consider what causes disability and MS and what it is all about. Most of you will know that in MS, the fatty covering of nerve axons, the myelin, becomes damaged in multiple sclerosis. So MS is all about the cells that manufacture myelin. They are called oligodendrocytes. And this is what they look like. They sit in rows on the axons, and they have numerous processes that wrap themselves around the axons. They are like little factories. They manufacture myelin continuously, and like any factory, they will need raw materials all the time to be able to do that. So they synthesize and maintain myelin, insulating and providing support to axons. But that is not all. Dr. George Bartsokis has published some very interesting articles about myelin. The brain intranet depends on the speed and synchrony provided by myelin. The thicker the myelin, the better it works, and the better your brain can function, similar to expanded bandwidth. Myelin increases the processing capacity of our brain intranet 3,000-fold. Some of these cognitive functions are dependent on later myelinating oligodendrocytes. That is why people of my age can learn to work with computers, and people can learn to play the piano at a later age. So it is actually possible for your oligodendrocytes to keep making myelin according to need. The scenario is like this. At optimal conditions for myelination, you have the oligodendrocytes merrily producing myelin. The microglia, immune cells in the brain, are at rest, and so are the oligodendrocyte precursor cells, which are stem cells that also reside in the brain. Now, sometimes there are adverse conditions for oligodendrocytes. You can see this oligodendrocyte is not happy. Some sort of insult has happened to it. A nutrient deficiency, or an attack by a toxin. So it undergoes suicide death, and it shrivels up and sends out distress signals to the microglia. Come and eat me, eat me. So the microglia wake up, they become activated, and they approach to investigate. And because the oligodendrocyte has died, the myelin becomes dysfunctional, and axons are exposed. And then the oligodendrocyte precursor cells wake up. Now, what do the microglia do? There are 3 important functions of microglia. They remove dead oligodendrocytes and digest them. They strip dysfunctional myelin from the axons. They clear up. This causes quite a lot of inflammation and free radical production, and the person experiences a relapse. But what microglia also do is to donate iron to the oligodendrocyte precursor cells so that they can mature and become new oligodendrocytes. Then remyelination occurs with clinical remission. That is why people who were paralyzed, a diagnosis, can walk again. So when the new oligodendrocytes remyelinate the axons, it leads to clinical remission and restoration of function. The microglia continue to remove the debris. But now, of course, the new oligodendrocytes are the new myelin-producing factories, and they will not be able to regenerate the myelin if they don't have the required nutrients, the raw materials. So there has got to be optimal blood flow to ship the raw materials to the factories. And if the new oligodendrocytes are subjected to the same adverse conditions that killed the previous ones, they will also die. Nutritional deficits are a major problem, and one of the worst toxins is cigarette smoke, and that includes passive inhalation of somebody else's smoke. Even though the oligodendrocyte precursors are called adult stem cells, they are little baby cells. Their antioxidant processing is not fully developed yet, so they really have to be protected. And if the microglia can't control the inflammation, peripheral immune cells are called in to help. Those are the B cells and the T cells from the blood. That is when people need cortisone to control the inflammation. If the inflammation is not controlled, the axons themselves may be damaged, and that is much more difficult to address than to protect the myelin. If you want to see what these cells look like in real life under a microscope, then have a look at the article by Barnett and Prenias. The reference is given at the end of this talk. Here is data to show the deleterious effect of smoking on MS. Here is the EDSS. You can see that many of the non-smokers have an EDSS of less than 3, so they have benign MS. Most of the smokers are not doing very well, but people who stop smoking can improve their outcome. When people join our research program and they are in a wheelchair, most times they are smokers. Some people do not smoke themselves, but when you ask them, you find out that their partner smokes. So they are constantly subjected to passive smoking. One poor woman was working at the tax revenue office in a closed environment, and she did not smoke, but everybody else smoked around her. So if you inhale smoke, you sabotage your own oligodendrocytes. It's a direct hit. In contrast, this graph shows the positive effects of eating fruits and vegetables. We asked people how many days a week they ate 5 or more portions of fruits and veggies. We actually found people who did not eat 5 fruits and veggies even 1 day a week, or only 1 day a week. And those people had a higher EDSS than those who regularly ate 5 fruits and vegetables every day of the week. And the EDSS decreased with every extra day that people ate their fruits and veggies. These results are an extension of data published by Davis et al. 2014. So which blood tests are the most meaningful to detect risk factors for disability progression? What we suggest is the following. Iron parameters, it's not good enough only to do hemoglobin and ferritin. Oligodendrocytes need the iron that is taken into the brain by transferrin. Then CRP for inflammation and vitamin D. Vitamin D is anti-inflammatory and it has a balancing effect on the immune system. Then you need to measure vascular risk factors, cholesterol and homocysteine, and you have to check folate and vitamin B12, which are needed by the oligodendrocytes to produce myelin. Our mission is to identify the risk factors for disability progression in specific individuals. Many of the risk factors have been known for many years, but some remain unknown. Smoking, stress, and a bad diet are general risk factors, but there are other risk factors that are specific for subsets of individuals, depending on genetic and environmental exposures. Our aim is to find out whether identification and avoidance of the risk factors in an individual leads to remyelination and recovery of function. Some of these risk factors have been known for such a long time. In the 1950s, it was found that saturated fatty acid is harmful for MS. In the 1960s, smoking, and people have still not registered it. In the 1970s, vitamin B12 deficiency. In the 1990s, vitamin D deficiency. And then we discovered that iron deficiency can be a risk factor in some individuals. This is a picture of the Faculty of Medicine and Health Sciences, University of Stellenbosch, and Tygerberg Academic Hospital, Cape Town, South Africa. If you would like to find out more about how to discover which risk factors are relevant for you, or to get more information, you may go to www.ssc.org www.brainbiochem.net and www.brainbiochem.com. If you would like to find out more about how to discover which genetic risk factors are relevant for you, you may go to www.genomics.com.